So this is Dr. Banerjee. Good morning, all. I'm going to start the conference, and I have the distinct pleasure of having one of my colleagues, Dr. Osvaldo Gigliotti, from the Director of Interventional Cardiology from Seton Heart Institute in Austin, Texas. And before we get on with the presentation, I would ask each one of you, if you're joining in or have joined in, to mute your lines. I think that will make it easier for Dr. Gigliotti to speak. If you do have a question, I think please unmute your line. This is an open forum, so feel free to interrupt and ask a projecting question. Absolutely do not mind that. There will be about a 5-minute Q&A session at the end of the presentation. And I know Dr. Gigliotti for over 3 years now. He's a phenomenal interventional cardiologist, has a significant number of peripheral interventions under his belt. He has a leadership role at the Society of Cardiovascular Interventions and Coronary Angiography at SCAI. And I'm really proud to have him today present this very important topic, that is the use of drug-coated stents for femoropopliteal interventions. Just to say that this is one of the fastest growing sectors of the peripheral market. And I think there are some important pieces of data. However, there is a lot unknown. So hopefully Dr. Gigliotti today will enlighten us with the facts and figures he has in store for us. So Dr. Gigliotti, please take it away. And thank you again for making time to do this presentation. Thank you very much.
Oh, you're welcome. Thank you too, Subhash. I hope you all can hear me okay. We've had a little phone difficulty this morning, but hopefully we will overcome that.
You're coming just and clear.
Oh, great. Thank you very much. I just wanted to echo what Subhash had said. Please feel free to interrupt me at any time, ask any questions, or if you have anything to contribute. As he mentioned, this is an open forum. So what we're going to talk about today is these drug-coated stents in SFA disease. And just quickly my disclosures. So we'll present a patient, very common to my practice and probably very common to your practice as well. It's an 81-year-old gentleman, history of coronary artery disease, strokes, hypertension, has very lifestyle-limiting claudication. He's a Rutherford Class 3 or Fontaine 2B. His primary care doctor ordered ABIs on him to kind of work this up, and his waveforms were not good. He had incompressible arteries on the right and a value of 1.26 on the left. They sent him for a CT angiogram showing sequential stenoses in the right SFA, and then included left SFA with good distal reconstitution. Just a quick refresher on some of the classifications that we use in our clinic and around to try to classify these people. And we'll show you this one frame from the angiogram. This is his left leg, and what you see here is the profundus coming in, and then the SFA with sluggish flow, and then about a 6-millimeter occlusion right in the distal SFA. He's got excellent runoff downstream here. So a patient like this, it's always what to do. I knew we needed to get through that to help relieve the symptoms. So using my standard equipment, just went up and over with a 7-French sheath, used heparin, which is a common anticoagulant that we use, and was easily able to cross with an 035 Trailblazer and stiff angle glide. Here just showing the wire passing easily through the proximal segment. You can see a little bit of stenosis up top here. At the end of the case, I measured a gradient across there and it was insignificant, so left that alone. And then I always like to, when I go through these occlusions, confirm that I truly am back in the vessel before I do any work. And this is through the Trailblazer. Note here at the about the adductor canal, there's also a stenosis present. And again, good runoff distally. So the question always comes up for me anyway, is always what to do. We do have a lot of options in treating SFA disease here in the United States. We can balloon, cryoplasty, regular stents, different types of atherectomy. when I have patients come talk to me in the clinic about the procedure, the first thing they always ask me is, well, you know, are you going to put a stent in? What are you going to do? And I don't know about y'all, but I tend to not have a consistent algorithm. A lot of how I treat a patient will be decided on sort of what the lesion subset is, what I see, kind of the feel of the case as I go along. We know that this is a very challenging segment to treat. I'm sure you all have seen the slides many times with the different types of forces that are on the vessels and really make it a challenge for us to treat. We also know that the data looking at durability of certain procedures has not been as good as we would like, especially when you look at the balloon data. As we go further out from the initial intervention, the patency rate is not too good, and the same thing we see with the stent. The longer we are from the stenting, the worse the patency rate becomes. Some more recent trials continue to kind of show this trend that stenting seems to have less restenosis than plain old balloon angioplasty, but still with rather significant restenosis rates. We see here almost 25% in 6 months, and even some of the newer stents, almost 20% in 12 months. And this is very frustrating for me because when we do a procedure, we like to fix our patients. We want to make sure that they are fixed well, fixed safely. And it's a little frustrating when you have to tell them, and I tell my patients, you know, there's about a 30% chance that you're going to have to come back and we're going to have to fix this again. So one of the new developments that we have, and we've been using recently, is the drug-eluting stent. These stents were initially started to prevent thrombosis with heparin coatings, and then the evolution progressing to inhibiting restenosis. We know from the coronary data that the polymers that are used to elute these drugs can also be thrombogenic and inflammatory. This is a nice slide from an upcoming publication showing the different types of drug-coated stents that are available. But here in the United States, the only one that we have available for use is the Zilver PTX, so we're going to talk about that one. This is an SFA stent. It is Paclitaxel coated. Now, I think for me, this was an interesting thing to learn. I used to think that these were, again, eluting stents, and there is no polymer. They have a proprietary formula, so the drug is applied directly to the metal. It works by you releasing the drug rather quickly. Most of the drug is delivered off of the stent within 3 days. But the absorption of the paclitaxel occurs for up to 56 days. As we know, paclitaxel inhibits cell proliferation, and ideally, with no inflammatory response from a polymer, the body can start remodeling and endothelialize, so to reduce clot formation. This graph here nicely just shows you that the amount of drug present on the stent is almost completely gone within 24 hours. And again, most of this is absorbed very quickly in the body, also within 24 hours, but can last up to 56 days, with most of it being gone within 2 weeks. Just to refresh the slide, the paclitaxel works in this stage of the cell cycle, different than some of the sirolimus and sirolimus analogs. The data for this comes from the Zilver PTX trial, basically 2 arms looking at patients here in the United States, Japan, and Germany being randomized to either the Zilver PTX or plain balloon angioplasty. And that was mandated by the FDA. They did not want to do a first-arm stent versus stent. And then if you failed angioplasty, you would be randomized again to either receive a Zilver PTX or a regular Zilver stent without drug coating. There's also a second arm, which is just straight stenting with the Zilver. looking at these patients, pretty common type patients that we would see in our practice. Lesion lengths in the mid 6 centimeter range, a variety of stenosis, a fair amount of total occlusions, diabetics, and most of these have a fair amount of calcification. With the single-arm trial or single-arm study, a little bit longer lesions here, perhaps a little bit more stenotic and more occluded, perhaps a little more challenging lesion subset. What we found after 1 year is that primary patency rates were excellent, with 86% primary patency as defined by a PSVR of less than 2.5. And 2-year freedom from target lesion revascularization of about 81%. This has now been going out to almost 4 years. This is, again, the 2-year data compared to balloon angioplasty. Again, consistent with what we see in most trials, that stenting does seem to confer benefit over plain old balloon angioplasty. When we take this out to 4 years, again, excellent patency rates of about 68% versus optimal balloon angioplasty and bare metal stenting. And I think for me, what I consider the most important as sort of a day-to-day cardiologist is the patient free from reintervention. And again, very excellent rates of TLR at 4 years. And again, excellent patency. There seems to be an equivalent effect in the diabetics and the non-diabetics. And again, with our long lesions, we still see all excellent results. Again, 67% primary patency in long lesions over 10 centimeters, and excellent freedom from target lesion revascularization in these lesions. Now, I just throw this slide in quickly, just because looking at some of the newer uncoated stents, they too have very excellent data. I mean, we can see freedom from clinically driven target lesion revascularization in the using the SMART stent in the Resilient trial. Again, 76% freedom at 3 years. Very, very good results. This also confirms, excuse me, the previous one was a stroll. This is actually Resilient with the barred stent. Again, excellent results, very similar to what we're seeing there. So I decided to try to use the Zilver PTX in this lesion. We have a limited supply. We only have the 80 centimeter stents, and this is a 6 by 80. What I'm showing you here is this is one of the challenges in using this stent. I don't know if this will show up well, but you see the stent right here and then the distal marker of the delivery catheter. Before you deploy this stent, you actually have to line this up, and this takes a fair amount of force. And what I wanted to show is that in the act of lining these up before you can really deploy the stent, there is a lot of movement, a lot of tension built up in the system. So I would caution you when you use this to take that into consideration, because because of the cost, you don't want to have to use more stents than you need. And then afterwards, a very nice angiographic results with good runoff. So the other population that we get a lot of the patients who come in with previously stented lesions and have in-stent restenosis. This is a patient who had, I don't know if this shows up, a Supera stent placed by another operator some time ago. And you can see he's got somewhat diffuse in-stent restenosis proximally, and then a de novo lesion distally. At the time I treated this patient, we really didn't have the Zilvers on hand. So what I ended up doing was just doing balloon angioplasty here, and then I extended this with a regular self-expanding nitinol stent with good results. Patient initially presented with a plantar wound. It healed up nicely. But it came back 6 months later, again with a wound, and what we see is the area of balloon angioplasty before, has restenosed, and even in the new stent, there is an area of restenosis. So rather frustrating for me. Looking at the data, this is a trial from Zeller, recently published, showing patients from the Zilver trial. They took 142 lesions, rather long, with in-stent restenosis. All these patients had in-stent restenosis, and treated them with a Zilver. And again, what they saw at 12 months was excellent primary patency in these patients. And even more importantly, an event-free survival rate of 60% at 2 years. This data was very well compared to other trials looking at in-stent restenosis. You can see a variety of treatments, including directional atherectomy, laser. The one that seems to have somewhat equivalent early results is balloon angioplasty and brachytherapy, although I would venture that this will probably never be a standard type treatment in most hospitals. This effect is long-lasting, again 96% freedom from target lesion revascularization at 6 months, and this study went out to 24 months, and again we see 61%. These patients had a marked improvement in their Rutherford score, their walking speeds, and their ABIs stayed consistently good. So coming up towards the end here, the other question with these stents is really the cost. Like most of you, cost is becoming more and more of a factor in our institutions. And there is a premium placed on the drug-coated stents here in the United States. So the question when I have to go to my cath lab manager is, why am I spending this extra money for the stent? Part of it is, hopefully I showed from some early data, that these stents are effective in treating your patients. There were 2 recent papers looking at the cost analysis. This is a paper looking at data from France, and all of these are based on models. So these stents have not been out long enough for us to really go back and look at large populations. So what they've done is made these economic models. And what we see here is that and this is in euros, is that again, as expected, there is going to be an incremental stent cost. As these stents cost more, as people become more familiar with it, there will be more of these used. But when you take into account fewer reinterventions, the savings will outweigh the cost. So long term, even though these are a more expensive technology, this will end up saving us money. This was the same type of model was shown in a recent paper in CCI, again using an analytical model from data from the United States and Germany. And when they looked at 4 treatments, including drug-coated balloons, what they saw is the same thing. Yes, these are expensive technologies, but you will get cost savings due to a decrease in target lesion revascularization. The one thing to note here is that the biggest savings potentially can be with the drug-coated balloons, although, as you know, they're not available in the United States just yet. This may end up becoming a factor in our armamentarium and in our treatments. So just to wrap this up a bit, these drug-coated stents, although you'll still even might use it in my slide, drug-eluting stents, they really are drug-coated stents, appear to be very effective in providing long-term freedom from target lesion revascularization, even in the long, complex lesions. They seem to be well suited for the treatment of in-stent restenosis. And despite the fact that there is a higher upfront cost, they may actually save money to the system due to fewer repeat interventions. This will still have to be borne out by data in the United States and again, maybe mitigated by the use of drug-coated balloons in the future. And also, as you remember from those earlier slides, perhaps even with the newer bare metal stents, maybe that effect of the drug coating is not worth the cost. So I'm going to end there.
Thank you, Bobby. Thank you very much. That was a fabulous presentation. It was to the point and really tried to answered the question that most clinicians and other folks who follow this field actually really have. I just want to begin with the first question for you, and I invite each one of you who have joined in on this conference call to opine and share your thoughts. However, the question from my side is that, at least in your practice, where do you tend to use more of stents, and especially the drug-coated stents? Is it only in total occlusions, ISRs, long lesions? You know, I'm familiar with this data. I see the long-term and intermediate-term good patency rates and overall clinical reduction in clinical need for target lesion revascularization with the Zilver. But there is as you would see, as you did point out, that there is some sort of a drop-off at the 100 millimeter lesion length or 10 centimeter lesion length. And at that lesion category, you know, it is slightly harder to make the point, is this really as good as, you know, it is for longer lesions. So this is the TLR rate. There's another slide where it was the patency, I think it was slightly lower. Yes. So the primary patency rates is slightly lower. And I think that that we were, you know, if you compare this with bare metal stents, so what would be the real benefit of this stent for longer lesions? So if you have a 67% patency rate with this, so it would be kind of 50% or maybe 50% with the bare metal if you take all the stents together. So how do you kind of put this data together for the real long lesions that you see? I mean, 10 centimeter is long, but as you know, for our interventional field, this is not as long as it gets. It can get fairly long, much longer than. So your comments and thoughts.
Yeah, that's an excellent point. I'm still trying to figure it out myself. When you know, as you know, it's very hard with stent trials because they're so variable.
Yes.
It's hard to compare the data from one trial to the next. And I agree with you. Most of the times, I'm not getting the nice, straightforward lesions. I get these total SFAs. And with the limited supply, the limited length of these drug-coated stents available, you know, I raised eyes if I'm going to use 4 of these to treat one patient. I mean, these stents are, as you know, quite expensive. So it's difficult still for me to know which one. I think where I'm finding I'm using them more is actually the smaller, shorter lesions that in the past I would use perhaps directional atherectomy and balloon angioplasty, trying to get a very nice result. But now with these drug-coated stents, I can use perhaps one stent and get excellent long-term results, and actually at a cheaper cost than using atherectomy and balloons. So again, right now I don't think, at least in my practice, I don't think I'm not using them for the very, very long lesions because of the cost. But I am using them for actually sort of more focal lesions.
That's a very interesting thought. Actually, I did not think of it that way, and I thank you for bringing that point up. But any additional questions or comments from people who have joined in on the call today? And while you think, and you can unmute your lines and comment, the other thing you brought up is that during your presentation, that in one of the slides, you actually did measure a lesion gradient, and that really caught my attention. So I want to just ask you, in your practice, how many times you actually do a hemodynamic assessment of a femoropopliteal lesion? We do it, and we have published it, but I was surprised that many other people do it too. And number 2 is, how do you actually measure it? Do you use a fractional flow reserve, or FFR guide wire, or you do a 4 French catheter? How do you actually assess those?
Yeah, I preach to everybody probably till they're sick of me saying it. You know, the angiogram is a liar. Many times lesions that you think are not significant tend up to be significant with 10 millimeters, 20 millimeter drops. So I try to measure gradients consistently, and I will just use a straight end-hole catheter, usually a 4 French, 5 French glide catheter.
I see.
I have not used an FFR wire. I think that's an interesting use of it, but again, in this era of cost, we try to keep everything as minimal as possible.
I agree. The final question is that what do you think about use of the Zilver PTX stent for in-stent restenosis? I think that's a very important area. And from Dr. Zeller's paper, it is evident that as soon as you use the word in-stent restenosis, the complexity of lesion length and number of serial stenosis within the stent of a bare metal significantly goes up. So there is a paradigm shift in terms of the complexity of lesions that we encounter for the in-stent restenosis patient population. So as you can see, 25 to 30% are in the TAS C, and 33% are greater than 15 centimeters, and total occlusion rates suddenly go up also. So I think that, do you think that it would be more important to use it in ISR, or do you use it in ISR, and what do you think about the use of DES only in ISR?
I think this is actually going to be an important niche for the technology. It may change when we get to drug-coated balloons, but I think from this paper, I mean, these are just excellent results. I mean, the case that I showed was one pre-drug-coated stents that we had, and again, really poor results after 6 months. And I think a lot of us see that. We bring these patients back over and over again and balloon them. I sometimes do directional atherectomy, different other therapies that people may have, lasers, etc. And again, not very satisfying results. So I think you can see from this table all these different technologies. This actually seems to be a very effective technology for patency, and more importantly for freedom from repeat revascularization. So I do think this is going to become much more used in treating ISR.
Well, that's an interesting thought. You know, personally, I actually differ from you on that point. I think I was thinking in terms of, and my thoughts were that in lesions where you actually need a scaffold, probably, you know, more complex and longer lesion, you know, I think balloon angioplasty, especially with the upcoming drug-coated balloons, would be will not provide probably standalone therapy for those lesions because you actually need a metallic scaffold. But once drug-coated balloons come to the market, I think for the ISR, where there's already a scaffold and the only function we actually need to achieve is maybe some atherectomy and suppression of the new intimal proliferation, I think drug-coated balloons might reduce the cost of treatment of ISRs and also may become the predominant therapy for those lesions because the scaffolding effect is not required for those lesions particularly.
Well, no, I would agree with you there. I mean, you know, sort of just, are we just reloading the stent, if you will? You know, the stent are deformed. You don't necessarily need more metal. But for right now, you know, they're not, as you know, not available in the U.S.
One final thought from me, and again, I invite all of you to jump in, is the use of dual antiplatelet therapy duration for DES in the periphery or drug-coated stents in the periphery. I think one of our team members presented a very good data, not for drug-coated stents, but bare metal stents at SCAI. I request you to take a look at it, and I think our group has also just got a paper accepted in JACC Interventions reviewing all drug-coated stents and drug-coated balloons. Karan Sarode has been the primary author with Dr. David Spelber from University of San Antonio on that paper, so I invite you to take a look at it. However, I just want to point out that in the IFU of the Zilver PTX, the minimally recommended period was 60 days, and I looked at the IFU particularly. However, 70% of patients got it for 3 months, and so I think that there is some area, and that number of 2 months was, I think, randomly selected, and I looked at the justification or the preliminary data for how they achieved that. I think that was not mentioned in the IFU, but nevertheless, I think 70%, 60% was minimum, 70% of patients received 3 months. So I think what we are doing in our practice, at least following that IFU recommendation for now, and we are preparing for a new clinical trial called ASPIRE, which is going to compare dual antiplatelet therapy durations after femoropopliteal and iliac and below the knee interventions overall. And for the first time, we'll actually randomize patients. So I encourage many of you to think about it and hopefully help us help by participating in that study. Well, if there are no additional questions, I would like to thank Dr. Gigliotti again for this absolutely to the point, wonderful cases and presentation. Your cases, by the way, Dr. Gigliotti, came out very clear. I think the transmission was very good, and your cases were had nice images, and we could really see them through very clearly what the points you were trying to make. So again, encourage each one of you to, if you have additional questions, maybe email Dr. Gigliotti or send me a message. I'll pass it on to him if you are shy in terms of speaking up today. However, I personally really enjoyed the presentation, and I would encourage each one of you to join in on future XLPAD webcasts. Again, remember, we start on time and we end on time, and we are right on the dot at 8:15, and we're going to end our conference here. And thank you again all for joining in.